to the presentation as well. In terms of the presentation, we do want to disclose that it was developed with an unrestricted education grant from Abbott, who are the makers of the Freestyle Libre. And so we do thank them for making this session possible, as well as the in-pharmacy campaign that whole health pharmacies will be having for our patients in the March timeframe.
Thank you, Tiana. I just wanted to take a minute and thank everybody for joining us here tonight. I made a map that shows where the registrations for this webinar are coming from. We do have people joining us from coast to coast in every single province except for Prince Edward Island. So I don't know if the Islanders are, maybe they're all in bed by now, who knows, but certainly appreciate the national audience. A little bit about Whole Health. We are an independent pharmacy banner. So if you are an existing independent pharmacy owner or thinking about ownership, certainly reach out to us. We'd be happy to talk with you. We'll be operating soon in almost every single province. We're still looking for some folks to be our first pharmacy operators in Manitoba. So if you're on the line in Manitoba and interested in Whole Health, for sure, reach out.
So today we'll start with a broad diabetes overview, which we'll move through quickly so that we can really focus more on the Freestyle Libre and the benefits and maybe some things to know about it. We'll then move into focusing on interpreting blood glucose. So one of the really nice things about the Freestyle Libre is it provides the data and the patterns so that pharmacists can make recommendations in changing management of patients' diabetes. So we'll talk a bit more about how to integrate that into your practice. And then lastly, we'll talk about which patients you might want to focus on specifically for this and some resources that we like that we'll share with you.
Yeah, very good. And as we move forward, Tiana is going to be monitoring the Q&A box in the Zoom, but also Facebook Live. So if you're on either platform, please feel free to give us some questions. I know we're going to move through a lot of material tonight, but I think we'll still have some time for questions. So please feel free to raise those issues and questions if you've got anything to ask.
Yeah, and so this is just highlighting that our whole health pharmacies pre-pandemic, as you can see in the note here, have participated in different diabetes initiatives and in World Diabetes events in the November timeframe. And so we're shifting that into a focus on innovations in diabetes, which include the Freestyle Libre.
Yeah, and as Tiana said, definitely these are pre-pandemic photos. If you go to our pharmacies nowadays, it's a very different situation. And we're going to talk about that a little bit, about diabetes care in the pandemic at one point in this talk as well. So jumping right into a quick overview and probably review for a lot of the folks on the line here tonight.
So we know that diabetes is quite prevalent in Canada. 1 in 3 Canadians is living with diabetes or pre-diabetes. And we know that there's a bit of a historical connection with diabetes in Canada, with insulin having been discovered by Banting in Canada over 100 years ago.
Yeah, that's quite a milestone that just passed over this fall. So something to be very proud of as a Canadian.
Now, we know that it's really important for us as pharmacists to help our patients manage their diabetes and really attain good blood glucose control, because when they have hyperglycemia and uncontrolled diabetes, they're at risk for a lot of complications. These include cardiovascular events, damage to kidneys, infections and resulting amputations, even things like diabetic ketoacidosis, which can result in hospitalization and even death. And overall reduced life expectancy. So we know it's really important to manage, and it can be hard to convey that to patients when things might not necessarily feel wrong, but we do need to drive home that message and really emphasize why they need to take an active role and how we can help them with that.
Yes, and we're going to be looking at a little bit of how guidelines have changed in the next couple slides to reflect some of these consequences of diabetes. So patients who are at risk for certain negative outcomes from diabetes. Now there's more targeted recommendations for various patient groups. So managing diabetes got a little bit more complicated last year.
And so we know that there is adverse events and outcomes associated with hyperglycemia, but this is also associated with hypoglycemia, so the opposite end of the spectrum. And so each person's reaction to low blood sugars might look different. And so it's important for patients to be able to recognize their own signs and symptoms so that they can treat them appropriately and in a timely manner. And again, there's a role for pharmacists in educating patients on what hypoglycemia looks like and helping them recognize what it looks like in them, and how maybe different devices can help them actually quantify how low their blood sugars are.
Yeah, at this point, I'd just like to share a little story about a patient with hypoglycemia. I mean, I have many, and I think we all do, but this one particular patient, those of you who know me know that I worked for a big box retailer for a number of years, managing pharmacies there. And I had a patient, well, I wouldn't call him a patient, but a shopper at the store come up to me one day, come up to the pharmacy counter, and he just kind of slumped over on the counter and asked to buy some needles. So I wasn't exactly sure what was going on with this gentleman. It was very early in the morning, and I went over to see what was happening and helping as much as I could. And I saw that loss prevention was following this fellow around the store. So they already raising alarms that this is a suspicious character in the store. So then my mind started to think, okay, am I dealing with somebody maybe who's using a substance, who's maybe having an overdose and slumping over on my counter? And I was able to get a chair to him and get him into the chair, and then I finally heard him say insulin. So at that point, I knew that this was actually a low blood sugar happening in front of me, where this man was basically, his sugars were dropping so low that he could no longer stand. So what I did was immediately get him some sugar. We had the Dex tablets just in the next aisle, so I got him those. And actually, he started to come around in about 10 minutes. And then he shared a story about, yes, he was a man who didn't have a lot of economic resources, so he looked a little bit rough. And that's why loss prevention was following him around with his backpack. But this guy, he was supposed to meet someone at the in-store McDonald's for breakfast. And he didn't have any money to buy his own breakfast. Yet he took his insulin, and then his friend didn't arrive, and his sugars crashed. So that was a big learning for me, because I'd never quite seen that low of a blood sugar in my practice rate at the store before. But it's right that hypoglycemia can look different for different patients. I've heard it say, spoken to, that the patient might appear to be drunk. So just keeping that in mind as we're practicing, you might very well encounter a similar patient one day. So, Tiana, I'm going to try to cover off this slide, and please feel free to add any additional commentary as we go through, because I think it's a really important slide, this one and the next one, reviewing the guideline update that came out last year. And I know that a lot of us pharmacists are really, with our busy practices through the pandemic, probably struggling more to keep up with guideline updates than we normally would have under ordinary circumstances. So there was a pretty big change came out last year, published by Diabetes Canada in the Canadian Journal of Diabetes, that really speaks to very customized choices of medications for particular patient groups with diabetes. So I'd encourage you all to take some time and actually read that update, because it's far more in depth than we'll get to here tonight. But I recall starting out as a CDE, was that 7 or 8 years ago, studying for the exam the first time. The guidelines started with lifestyle plus and minus metformin. And then once you do that, it was pretty much anything else. So the guidelines have changed quite a lot over these last few years in terms of, yes, we're still starting with metformin, but then there's a lot more direction about what that next agent should be. So this chart here speaks to adjusting or advancing therapy with regard to, if you go down the left-hand side, if you have patients with established cardiovascular disease or chronic kidney disease or heart failure, or even if you have a patient over 60 years with cardiovascular risk factors, there's particular agents that have shown evidence in preventing certain negative outcomes. So whether that's progression of nephropathy or the MACE score, which is a composite score, which includes MI, stroke, or cardiovascular death. So keeping in mind those target populations going down the left-hand side, if we go back to the right-hand side of the screen, and we're just talking about patients who are not meeting their A1C targets, and they need to have an additional glucose-lowering therapy, again, this box is very dense around which agents and for which patients. So if you have a patient and you think they might be at risk of cardiovascular disease, well, you probably want to pick one of these agents that has a demonstrated cardiorenal benefit. And it gets even more tricky because it's not just a class effect anymore. So we talk about GLP-1 receptor agonists. Well, there's 3 out of the 5 there that have the evidence. So it's not just a class effect. And again, if we look at the SGLT2 inhibitors, again, there's 3 out of the 4 that are showing some proven cardiorenal benefits. And again, in addition, if you're looking at a patient that could benefit from some weight loss, we have evidence that these classes of medications also can help with weight loss. And for moving further down in the slide, you'll see that the DPP-4 inhibitors are there as choices. However, they're under the category that they don't necessarily have a proven cardiorenal benefit. And there's one in particular, saxagliptin, that actually might have flagged a risk of heart failure. So you especially would not want to use that in a patient who would be at risk of heart failure. And then down at the bottom there, there's agents that we really are trying to get away from using. For example, sulfonylureas and the TZDs, which I don't know if anybody has a patient on one anymore, but I did have a patient on pioglitazone who was very reluctant to let go of that. And I even had a patient who was on Avandia until he couldn't get it anymore. So I guess patients also are decision makers. You can explain to them the risks, but they are involved in the process as well. Tiana, did you want to add anything on this slide?
The only thing I'll add is just that there is a lot of information, but it's also a really good opportunity to really make sure that patients' diabetes care is optimized. So now we can start looking at it more specifically and kind of screen, okay, does this patient have cardiovascular disease? If so, which of these agents do I want? Do they have chronic kidney disease or heart failure? If so, which agents have evidence for things like reduced hospitalization or reduced mortality? And that's something that we haven't really had in terms of outcomes since metformin, essentially. And then there's also an opportunity for patients who, like James was saying, were really on the older therapies, but maybe a little stuck in their ways or their prescribers' ways. Even with things like the sulfonylureas, we want to shift away from that and then pick a specific agent based on their specific cardio or renal risk factors.
Yeah, and I mean, we still see sulfonylureas, metaglinides on this chart. And we were talking between us, Tiana, earlier about how, particular provinces might be making it harder to follow best practices. So we know that there are certain provinces that would require a patient to try sulfonylurea before they might access some of these newer, more expensive agents. So, I mean, you still have to work within the limitations of your particular province's formulary. So this slide here again it's pretty exciting to me. I know that might make me a nerd, but now we're talking about once we add insulin, a basal insulin, so this would be for a patient with type 2 diabetes, how there's a lot more clarity around which agents might flow next. So there's strong recommendations here to start as a next agent rather than going to like a basal bolus insulin regimen for patients, to actually add on a GLP-1 receptor agonist or an SGLT2 inhibitor. And I actually really like how this chart in the small print added in to stop the DPP-4 inhibitor. That's a question that I get a lot from pharmacists. So I started a patient on Victoza, but the doctor is saying to keep them on a DPP-4 inhibitor. So that could be maybe Januvia. So how do you manage that? Well, now we have a strong guideline telling us, make sure you don't, because there really is no benefit to adding that, to keeping that DPP-4 inhibitor if we're going to have a GLP-1 receptor agonist. Yeah, so it's kind of like a chart as you move down. It tells you what to do for even what potentially could be a fourth agent. So we could have metformin, a basal insulin, say we added a GLP-1 receptor agonist. If we're still not meeting our glycemic targets, then you could consider adding an SGLT2 inhibitor. So all of that before doing a stepwise insulin increase with adding a mealtime insulin and then escalating from there.
And so, James, like you mentioned, this is a big shift where traditionally patients who are on oral agents moving to insulin, essentially they were all stopped except for metformin, and then the insulin was started and optimized. But this is different. So what do you suggest doing if the patient is a patient whose other oral agents were stopped? They're now on insulin and metformin. Now what do you do?
It gets a little more complex there, doesn't it, Tiana? So I think it's in the patient's best interest to talk to them about new evidence that's coming out about agents that could potentially convey additional benefits in terms of preventing some of these serious consequences. It's an individual decision, but I would consider, in collaboration with their primary care provider, introducing some of these agents and trying to reduce or even eliminate some of their bolus insulin doses. I think it would be a gradual transition, of course.
James, I don't know if you actually saw this question, and that's what prompted some of your comments, but somebody asked specifically about the DPP-4 inhibitor when adding a GLP-1 receptor agonist. So it's exactly what you're saying. You get the question a lot.
I love that. I actually didn't see the question, but that is a question I get from pharmacists the most. And it actually causes some headbutting, I think, between prescribers and pharmacists, because pharmacists are saying, this doesn't make sense. We're giving like super therapeutic doses of GLP-1 receptor agonists compared to what you would have endogenously, yet you still want to have a DPP-4 inhibitor. It doesn't make any sense at all. So I'm actually very excited to see that in this chart. So I'll move along, but sure, keep the questions coming, folks. We love it, and happy to answer them. So probably most of you have seen this before because it dates back to the previous guidelines, but we started talking about, maybe the target of 7 for A1C is not for everybody. That's the way it used to be probably 6 or 7 years ago, where what's the A1C target? Everybody had the same target. But now we're more into individual targets. So if you have a relatively healthy person with diabetes and they have many years left in their life, So I would always think about like my own mother when I was looking at these targets who has type 2 diabetes. I would say I'd want to treat my mother's diabetes a little bit more aggressively because her diabetes is relatively well controlled and she's not a frail elderly person. So maybe a target slightly less, maybe 6.5 would be appropriate for her. However, if you're dealing with a frail elderly person who has difficulty managing their medications and they have a higher risk of hypoglycemia, you might want to have a target slightly higher for them. So even up to 8 or even 8.5 in some cases may be appropriate. So we really need to consider what those individual targets are for the patient one by one. So we're not going to read through this box of text, but it's more just to flag this for you that what we're talking about tonight, flash glucose monitoring, it is now part of the Diabetes Canada recommendations that this is an appropriate technology to offer patients with diabetes because we have some good evidence that it can reduce the time patients spend in a hypoglycemic state. So if you want to read up on the trials, please go ahead and spend some time with that. Transitioning into the next section, we're going to dive right into the Freestyle Libre, which probably a lot of you see at your pharmacies and are likely familiar with, but we're going to go into some tips and tricks and details that you may not have seen before. Starting with just a quick review of what is, how does it work, the Freestyle Libre. So it is a flash glucose monitoring system. It comes with a loading device, and there's a little filament, you can see it on the slide, this vertical line over here that is introduced there's a needle on the loading device that helps guide that filament, but it's actually a soft filament that remains in the interstitial fluid, which is connected to the sensor that can store the data. And unlike finger pricks that measure capillary, why can't I say that word? Capillary blood, it's a late night for me, I guess. This one is actually measuring the interstitial fluid. So there's actually times if you were to do a finger prick and scan, you scan the disc that's stuck on your arm, you might have a different number because there's actually a bit of a lag for the blood glucose to enter the interstitial fluid and come to an equilibrium. So especially say after a mealtime when your blood sugars are changing more rapidly, you might experience slightly different numbers comparing them. Now this device that it's stuck on your arm for 2 weeks at a time, and that's always a little bit shocking when I tell patients. They're always a little bit perplexed. Yes, you're going to wear this thing for 2 weeks at a time, and then we change it. And that was always, just to see the surprise on their face was always funny. But this disc, it can be read a couple different ways. So you can use either a reader, or modern smartphones, iPhones and Android devices can actually read the sensor itself with an app.
And I'll just mention that we have a question, I think asking around if we'll talk about the Freestyle Libre 2. And so we will get to that at more the end of the presentation where we'll chat a bit about that. So stick with us and we'll touch on that.
Yeah, so we'll save the question on the Libre 2 for the end so we can tell folks about the original Libre first before we review the changes. Okay, Tiana, I'll let you take this one.
Perfect. Okay, so in terms of the Freestyle Libre, it is factory calibrated. So when patients have it, they don't need to calibrate it themselves. And the values can be displayed once the sensor is flashed with the reader. So that can be done on either the app or on the reader. The sensor records the interstitial fluid and the glucose there quite frequently, but actually keeps it every 15 minutes. And so the capacity that it has is to store data for up to 8 hours, which means that people who are wearing this device need to scan it at least every 8 hours in order for the data to actually be transferred and stored. And that's how we end up getting the 24-hour glucose profile, by getting those at least 3 scans that are no more than 8 hours apart. If you scan less frequently than that, then it'll only have the last 8 hours worth of data that it can transfer over to the app or the reader. And then, as James said, patients will scan it and wear it for 14 days. We are getting some questions, James. So someone is asking, just to clarify, which is more accurate, the finger prick or interstitial fluid?
That's a really good question. So we're going to talk about it a little bit more in this presentation, but they're very different readings. May as well address the question right now. So what you're getting with a flash glucose monitor, it's trends, and if the patient scans enough, you can get the full 24-hour picture for what that patient's blood sugar or interstitial sugar is doing. However, it's not a number that you can make decisions in a moment using. So say a patient is experiencing, they scan their reader and they're seeing they're trending low. Well, you definitely want to confirm that with a finger prick before, as you're deciding how you're going to handle that low blood sugar. Because if it's showing low in your interstitial fluid, potentially it could be even lower in your blood. And there's times, say you want to do a correction factor and do an insulin dose. You wouldn't want to calculate a correction factor off of your interstitial fluid. You'd want to know what your blood sugar was at that time. So definitely there's value to both. And we don't have a slide about it in the presentation, but the Libre meter itself, it does take test strips because there's times when a patient will need to do a finger prick. And yeah, so both readings have quite a lot of value.
I think that answers another question that we've gotten, which is any reason why someone may have a low reading with the Libre, but a 5.9 with a capillary blood sugar reading. And so that James has touched on, because there's a bit of a lag with the interstitial fluid, you might not be seeing where it's going. And so that's why looking at it in terms of the whole picture and the trends, which we'll talk about in a couple of slides, is really important.
Yes, exactly. Should we move ahead, Tiana? Okay.
I think so.
Great.
So we'll show you a small video from both a former Whole Health pharmacist and a friend of Whole Health Pharmacies, and it'll just show what the actual application looks like, so that you know what you're about to counsel patients on and what they really experience. And you can see that they perceive the experience a little bit differently, relatively smooth application and no pain, depending on who you talk to. So we'll let James start it off here.
Okay, just give me a minute to cue it up here. So you guys can watch the whole video later, but we're going to skip to the part where Salima and Michael are applying the sensors.
Okay, so what we're going to do is step one. We've chosen the arm that we're going to use. Yeah, you're going to use that one. And we're going to alcohol swab. We're going to clean the site. So you should be using a flat site. This does have to dry before you go ahead and put the sensor on. It's really important that the patient knows that their skin shouldn't be oily. If there's a lot of hair there, make sure that they shave it off. It'll just help the sensor stick better. The actual sensor's in here, and this is the applicator, as we said. You'll notice on the applicator, there's a line here, Okay, you're gonna have to line that dark line up with the dark line located in this sensor. So shall we go ahead and do that?
Let's do it.
Okay, so we're gonna be applying these differently. If you watch any of the videos as to how to apply this, they always say to choose the back of your arm and press. Michael knows a bit of a trick where you put it underneath, right? And it's supposed to stick better.
Yes.
Yeah, okay, so we're gonna try each one of those and see how it works. But we only have one shot, so let's make sure this is a good one. So peeling this back. All right, that's what it looks like. And let's go ahead and remove this so it's sealed really well. That's what it looks like. Cheers. So the line here, like I said, is going to line up with this line. So let's go ahead and do that, and it should lock into place. And I think we should hear a click. Yeah. Okay. I'm a little bit nervous. Should I be? Okay. So that's it. That's what it is. So what you'll see, what your patient will see is a needle. That needle is not going to stay in the arm forever. It's actually going to be a microfilament sensor that gets placed into the arm. The needle just helps with the placement of it. So, okay. Shall we?
Yep.
Okay. I'm nervous. Did it hurt? Did it hurt?
No.
Did it hurt?
No.
Okay. Okay. I felt a little bit of a prick, but not too much. And now? All right, that's it. We're done. So
That was great. So yeah, please check out the rest of the video for watching Salima and Michael reviewing and unboxing Freestyle Libre.
And our next slides go into more depth as well if you want to take a look at it, kind of step by step to help walk patients through their first application.
Yeah, so you saw in the video where Salima and Michael used it comes with an alcohol swab in the box, which you can use to clean the site. Make sure you let the site dry before the patient would apply. You have two pieces. So the one piece is the tray with the sensor inside, and then there's the applicator, which you have to screw off the cap. And you saw in the video, Salima mentioned how you have to line up. There's a black line on the applicator, and you line it up with the black mark on the tray, and you press it down firmly, and then you lift it out. And then to finally apply, you choose a site towards the back of the arm, and the patient should try and choose a spot on the arm that's a more flat surface area, away from any scars or tattoos or abnormal tissue, and they press down firmly, and that applies the sensor.
And James, one of the things you and I were talking about earlier is that sometimes this can be a bit scary for patients just because it's their first time applying it. And as you saw with Salima, she was a little bit timid, a little bit unsure. So we were talking about having the patient doing it themselves in the private counseling room with just the pharmacist there to support so that they don't feel alone, and you can coach them through the steps.
Yeah, so the next couple slides include some more tips. So make sure the area is dry. Like if it was dry and then alcohol and then evaporated, usually that's pretty dry. However, in some cases, I might need to pat dry before applying. Avoid using tight clothes, especially so that if you pull down a sleeve, it doesn't pull off that sensor. Because when you first put it on, it might take a little while to fully adhere. The sites, the preferred sites are on the back of the upper arm. Some challenges with that site, if it's not on the back side, but more around to the side of the arm, patients tend to knock them off on door frames or other objects like that as they walk by. And I've actually had that happen to patients. So trying to get it towards the back is great. And I really like that alternative technique that they showed in the video. Encouraging patients not to pull on the sensors or touch the sensors. And there's some options on the next slide in terms of dressings and techniques to make the sensors adhere better. So a very popular option is this skin tack where you wipe the site and it actually makes, before you apply the sensor, it makes it a bit more gummy so the sensor adheres better. As the sensor is on the arm, as we talked about, it stays there for 2 weeks. So patients should try and watch to see if the edges are starting to lift at all. And that might be a sign that they need to take some additional intervention to stop that sensor from coming off fully. So there's different things to do. For example, I was quite popular among my patients to put a Tegaderm film over top, which would help hold it in place. Or a lot of more active patients are actually going to physiotherapy tape, such as a KT tape, cutting a strip of that, and you trim the edges so it's rounded, and then applying that over top of the disc is helpful. And there's also some other dressings called over bandages that you could offer to patients. So there's lots of tips and tricks there to help keep the sensor in place.
So James, you've answered another one of the questions, which is what do you do if it keeps falling off? Another question that we're getting is, are you allowed to apply the sensor for a patient? Some of them are afraid to do it, like we talked about the first time, despite watching the same video on YouTube. So what do you suggest there?
That's a really good question. And I think that there would be probably some provincial variation to the answer to that question. So I could speak to here in Ontario, where I practice, that it is within the scope of practice of a pharmacist to perform a procedure below the dermis for the purpose of training a patient. So if you needed to train a patient on how to apply the sensor, it's my opinion you certainly could help them apply that first sensor. And once they have been through that experience, they probably have the comfort to do it themselves the next time. Another thing to talk about is what happens at 2 weeks when we need to take that sensor off. And it's not called out specifically on the slide, but for some people, they have trouble keeping sensors on, but for some people, they have difficulty getting them off. So because depending on your skin type, you might have a more oily skin, which makes it harder to keep a sensor, or if you have very dry skin, sensors might really stick to you quite well. So what's recommended is to use some oil, such as a baby oil, and just work that around the edge of the adhesive underneath the disc so that the edges start to lift. And it can take several minutes to just slowly dissolve the adhesive. There's also some wipes you can get to help with removing adhesive.
James, we'll just do 2 last questions and then we'll move on and see what we have time for at the end. But one of them is asking for the advice where you gave in terms of keeping it on, is it okay to cover the sensor completely with something like Tegaderm, or do you need to cut a hole?
You can cover the whole sensor actually. So if you watch that video of Salima, you'll see how she reads the sensor all the way through her winter coat at the end. So you don't need to have a hole in the middle of this bandage on the screen shows a hole, but folks are putting Tegaderm film over top without any hole at all. So you can certainly do that.
And then the second question I'll ask here is, what's the basis for the 14 days? I heard some patients have tried leaving it on for more than 14 days to save some money.
My understanding is the sensor will time out and it will tell you to exchange the sensor when you try and read it, Tiana.
I think one important thing to keep in mind too is that 14 days is the duration that it's been studied for in the literature. And so I think after that, the calibration is something we're not as sure about. So if that's an only option, and that's the decision the patient's made, then that's when potentially we need to turn to some more frequent finger pricks to see if it still is calibrated for that patient. Now, we won't spend too much time here, but if you're talking to patients, some key points about the benefits of the Freestyle Libre that were found in randomized controlled trials in patients here with type 2 diabetes, but there's also trials with type 1 diabetes, but found that there was reduced finger pricks, which makes complete sense. That's what we would expect. But importantly, it also reduced the time in hypoglycemia at less than 3.9 and also values less than 3.1, so more severe hypoglycemia. It also reduced nocturnal hypoglycemia, which we know is dangerous, as when people are sleeping, they might not notice the earlier warning signs and can get to the more severe states more quickly without detection and reaction. It also reduced glycemic variability and improved quality of life. So people enjoyed that they didn't have to be pricking themselves and feeling that pain and could just more easily swipe, essentially.
Yeah, not to dwell on this slide, Tiana, but another story about a particular patient. You know, you think you're doing a pretty good job as a pharmacist, you're a CDE, and you think the patient's sugars are pretty good from what they show you. Like their A1C is good and their occasional finger pricks through the day are fine. So you carry on. And when you throw in as one of these Libre sensors on them, it can really shake up how you approach diabetes care, because this patient, who otherwise seemed to be well controlled, was having low blood sugars through the night. And without this device, like, she's a senior lady, she wasn't going to test her sugars in the middle of the night. But without this data, we never would have found out. And of course, that would be causing her harm. So it's very powerful technology.
Now, for as many benefits as there are also limitations, which we just want to make sure that the pharmacists and the patients are aware of so that we can address them appropriately. So one of the things we talked about was that there is a lag time. So the sensor glucose follows blood glucose because that blood does have to travel through the interstitial fluid. And so we want to look at things like trends, and we'll show you arrows in a bit to show you how patients can kind of predict where they might be and respond appropriately. And if values are changing really quickly, that's when we want to use some finger pricks instead. It also takes some time to warm up. So for the first 60 minutes, the reader might be slower and more variable for the first 24 hours as well. And then we've heard stories and had experiences where readings have been impacted by things like dehydration, vitamin C, and salicylates. So vitamin C can cause falsely increased readings, so the readings might be higher, and so people might then treat hyperglycemia when they're not truly experiencing it. And with salicylates, it might be falsely lowering the readings, which could lead people to treating hypoglycemia, but also thinking that their diabetes is more well controlled than it is, and potentially lowering things like their insulin dose. So if patients are on these, and you would want to screen them when you're starting the Freestyle Libre, you might want to account for that and do use the finger pricks to see what the difference is and how you can take that into account for your patient.
Yeah, that's a really important message. And Tiana, like during the pandemic, we're seeing such a interest in immunity, and folks might be actually taking more vitamin C than they otherwise would. And even during a typical cough and cold season, you'll see patients buying multiple bottles of vitamin C because they think that's going to keep them well. So just maybe flagging that for your diabetes patients, reminding them if you're using a Libre sensor, vitamin C might actually affect your numbers.
And now we touched on this a bit already, but when do we use the finger prick? So at times when there's rapid glucose changes, and you'll see the actual arrow, kind of the degree of the slant will tell you how quickly glucose values are changing. So if it's quite steep, then you will need to tell your patients to monitor more often with a finger prick. If there is hypoglycemia or impending hypoglycemia, again, because there's that lag, we want to make sure we turn to the finger prick to understand what the true value is and if it's responding to how we're treating that. And lastly, if the symptoms aren't matching the glucose levels on the scans, that should be a bit of a warning sign that maybe it's not calibrated, or it could be that it's falling out a little bit already. The filament may have moved, and so it's not reading as accurately. So again, that would be a time to prick. And also a good reason why we still need to have conversations with patients about what hypoglycemia looks like for them and in them.
Yeah, so some other times when blood sugars might be rapidly changing, so it could be during exercise. So if you have a very active patient and they're exercising, suddenly they're feeling some symptoms of a low, well, they'd want a finger prick at that moment. It's not a time to flash your reader. Dan, I see like the question box flashing. I don't know anything we wanted to handle right now. So I'll take the slide about coverage while you're looking at that.
Yeah, let me read these questions here.
Okay. So in terms of coverage, unfortunately, a number of provinces, in fact, most of the provinces, do not have coverage on provincial plans. Last time we checked, it was just Ontario and Quebec that offer coverage, and the criteria in both provinces is similar, that it's for patients on insulin therapy with a prescription from a physician or a nurse practitioner. So this is unfortunately something a pharmacist cannot prescribe for a patient. And the other provinces where whole health operates, so BC, Alberta, Saskatchewan, New Brunswick, it's not yet listed on provincial formularies. There is potential for a patient on the NIHB plan to receive this. However, it is what we call an exception product. So if you receive a prescription and the patient has NIHB, you need to call the access center, exception center, and then typically they would send a letter to the prescriber, and that would be filled in, and they would decide whether it's approved or not. A lot of my patients receiving the Freestyle Libre are patients on private plans. So folks who have like Manulife or Green Shield or what have you. Any questions?
So I've got some questions here. Yeah. So I think this one we touched on a little bit, but is it true that the sensor is also a glucose meter, and what strips do you use?
Yeah, so the sensor is not a reader, but the reader takes the Freestyle precision strips. So I don't know if I hold this up, if you can see, like at the bottom of the reader, there's the spot where you insert a test strip. And the Freestyle Precision, it's actually an older test strip, been on the market quite a while. They're the much larger ones, and they're individually wrapped in foil within the box. So a lot of pharmacists are more familiar with other brands like Essentia or One Touch, but it does take test strips. So patients have the choice of doing their finger pricks and using their reader, or some patients actually will use another meter, and that's okay too.
And James, the reader, it's specific to blood, or does it also do ketones?
This one does not do ketones, I think. Yeah. Yeah, so you would need Precision Neo, which also does ketones and would use the Freestyle Precision strips. So there's another meter for ketones.
Okay, and then another question. There's a patient who has quite loose skin where we're asking people to apply the sensor. Where would we suggest they use instead, or do you have any tips? Would they use the top of their arm?
Wow, that's I could see how it would be hard to apply the sensor onto loose skin. So unfortunately, the device is not approved for other sites, so I can't really recommend an alternative site. I know that patients are applying on other sites, so for example, forearm or on top of the thigh, but it's not really approved on alternative sites. So if that's happening, probably at least at the beginning, you'd want to do additional finger pricks just to make sure that they're getting reasonably reliable results. You could apply over top like a physiotherapy tape, like a KT tape, to help hold it in place. But I could see how applying on a loose skin might be a bit more challenging. Probably when they first apply it, one tip is to use like a blunt object, like the handle end of a spoon, and just press around the margins to make sure it's well adhered. That might help as well. For some patients, it might not be an option. Like if you can't get the sensor to stick based on their anatomy, I could see that some patients might need to rely on finger pricks instead.
And two things I'll just add. One, the presentation will be emailed out to participants. People are asking. And one, it does in fact measure ketones. So in addition to blood glucose, we can also measure some ketones. Okay, and then there's one question. This will be the last one, kind of a combo question. The first is, what's the ODB criteria? And also, if the sensor is faulty or does fall off, can I bill ODB again for another sensor?
So the criteria here on the slide, so ODB recipients on insulin therapy with a valid prescription. So in terms of if it falls off, can you bill for another one? Not really, no, but the ODB policy, it does actually allow more sensors per year than a patient would actually require. So there is a bit of liberty there, or wiggle room, I would say. If the patient is a week early, 2 weeks early at the end of their fill, I would document the reason why, and sensor fell off, patient needed it early, and I don't think you'd have any difficulty with that.
Okay, we'll keep moving just to keep going, and we'll loop back if we have extra time later.
We're certainly grateful to have an engaged audience with lots of questions.
Yeah.
I love it. So thank you so much. So the next section, we're going to be talking about some of the reports that we get out of the Freestyle Libre and what you can do with those reports. So again, maybe this is a better visual on the slide. You can see here where the test strips can enter into the reader at the bottom. We're going to talk about the Freestyle Libre link, which is a mobile app, some of the reports you can get, and also Libre View, which is a platform patients can use to look at their data and reporting, but also they can share that with healthcare providers, including their pharmacist. So Libre View is a platform where I think it's really quite exciting what this can open the door for, because over this last year, I know that my own doctor is not seeing patients personally unless it's like an absolute emergency. So probably a lot of your diabetes patients are out there in the community by themselves, not receiving the appropriate follow-up and chronic care management they require for their diabetes. And this is really an incredible opportunity for pharmacists to step in and help. And there are a couple ways that patients can share their data with you. As a healthcare provider, you can either give them your provider code that you can register to receive, or you can send them an invitation when you enter their email so that they can grant you access to look at their data. So I could see pharmacists interested in diabetes or CDE pharmacists really doing quite a lot with this, especially during the pandemic. Tiana, I think you were going to present.
So when we do look at the readings, we want to use the information from the scan to make clinical decisions, but we want to use that information within a certain context. So we don't want to just look at the present value. That would be kind of like measuring just a finger prick at one point in time. We also want to look at the past and the future. So we see the big here 6.2, which is the current glucose. But if you see on the right in both the app and the reader, we see an arrow that's pointing upwards to the right. And really that's the glucose trend arrow. So that's where we're going and where we will be soon, which is important to know, especially because there is that lag. We'll also walk you through a few different glucose graphs so you can see things like variability and different things that you might want to address, like hypoglycemia or amount of reading. And then lastly, there's an area at the bottom where you might be able to see in really small, it's a little pencil in blue, and it says add note. And so we want to look at those notes because patients might add things like exercise, or they ate, or they injected insulin. And those are important things so that when we're looking at trends, we have an understanding of maybe why blood sugars are the way they are. Yes. Now, when we look at those glucose trends,
Ken, I was just going to add that the notes, you can add notes in the reader up here, or you can use add note at the bottom of the app. So the patient has a couple options where they can share additional information.
And moving on here to the next slide, when we look at the glucose trend arrows, we see where that glucose is heading, and we can see the arrows kind of straight up or straight down, which means that the glucose is rising quickly or falling quickly. And when we look at what that really means to the patient, it means that their blood glucose level is going to change by 1.5 millimoles in the next 15 minutes. So for example, if their blood sugars are already at 3.5 and they're seeing that their value is an arrow pointing straight down, they're falling quickly. And in the next 15 minutes, if no action's taken, they're going to move from 3.5, which is hypoglycemia, as we know, to 2, which would be quite severe hypoglycemia. So they do need to act quickly. And that's one of the benefits of being able to see where you're going. You might see things that are less extreme, things like rising, so it's at about a 45-degree angle, or falling, where blood sugars are going to change by about 0.9 to 1.5 millimoles in the next 15 minutes, or a horizontal arrow where there's minimal change in the next 15 minutes. Now, like we talked about, there is a little bit of a lag between self-monitoring blood glucose, and it can vary, but it's about 5 minutes. And so that's one of the questions we got as well. How much is that lag? About 5 minutes.
Yeah, great question. And I find that these arrows are very helpful. If you have a patient and you see that they're trending falling quickly or just falling, and they're in the lower glucose range, like say they're at 5, probably they want to confirm what's happening with a finger prick. If they're at 5 and falling, that would be very concerning. And times when you might see rising quickly, not necessarily an emergency, but say if they're always getting rising quickly after eating certain kinds of foods, well, maybe they want to look at nutrition, and maybe I can make choices of foods with less carbs or lower glycemic index, or maybe combine these carbs with some protein to blunt that sugar spike. So lots of things here that pharmacists could give good recommendations with. So the sensor usage report is an important one to review with patients, because it really will reflect the robustness of the data you're receiving if patients are not getting you the majority of their sensor data. So the goal, it's encouraged to try and have at least 70% of sensor data. I mean, I'd encourage patients to get actively involved in their care to push that number higher. ways to do that. So they could time their reads with their daily routines. So maybe they scan their reader first thing every morning and at every meal and at bedtime, and say they wake up in the night, they scan it then as well. Or another approach could be to schedule some alarms in the cell phone reminding a patient to scan their reader. So this report is very, very important. So low glucose events report. So for pharmacists, whenever you're managing a patient's, helping a patient manage their own blood sugars, you always want to go to the low blood sugars first. So if you see on this report, there's 10 events and 6 of them are in the evening within the last 7 days. So you might want to ask the patient a little bit about their daily routines and their medications, and that's something a pharmacist could certainly help. So say if they're on multiple daily doses of insulin and their dinner dose of insulin was too high, you could help the patient lower that dose and potentially mitigate these low blood sugar events. So there's another report called Time and Target, which really, it's a quick look at the overall control of the patient's blood sugar. And ideally, like the goal is to have less than 4% of time in hypoglycemia. I would try and target 0 if I could, but I guess 4 is the recommended guideline, and ideally at least 70% in range. This reports the average glucose report, where it gives the times of the day over the last 2-week period of data. So it gives you the average for each hour of the day and identifies them green, red, orange. So it really guides you to where the patients are out of range, and you can work with the patient to address those challenges when they're not quite meeting targets. Okay, so daily pattern report, and this one I think is really a lot of information on a simple graph, but it gives you an idea of the variability of the patient's blood sugar readings. So a patient with very tight glycemic control, these bands, these lighter shaded colors of bands, the blues, will become narrower. So the goal would be to get those as tight as possible so that the patient's blood sugars are not widely ranging throughout these time periods when you look at the average across the last 2 weeks. So the last report we're going to show you is something that is only available in the app. So we didn't really say, but at the beginning, when a patient receives the Libre sensors, they can choose to have the reader or not. Like some patients I've had just elect to use their iPhone or their Android device as the reader, and they would have the ability to see this estimated A1C in the mobile app.
Before you move on, James, I'll just ask some questions that have come up from the audience here associated with the different reports. So one of the questions is, how do you become aware of nocturnal hypoglycemia if the patient's not using the sensor during the night?
Yeah, so the sensor records 8 hours, the previous 8 hours of data. So they don't necessarily have to read it first thing, like in the middle of the night. But if they get up at 7 a.m. and they read it, it's going to get captured most of the night. It's certainly not perfect, Like, it is one of the weaknesses of the Libre that it doesn't capture more than 8 hours at a time. But we're going to talk to the Libre 2 a little bit later on, how that problem is likely going to be fixed.
Yeah, and then the last one I'll ask is, can you explain again the daily report versus the 14-day average report?
Are we talking about daily patterns report or?
Yeah, I think so.
So the daily patterns report, it is the 14-day average. So it's giving you the variability, say every day around, like the average of my blood sugars for the last 2 weeks at noon. So the black line would be the average. And then the lighter blue and the two sections here, they basically describe the variation in that data. So if you have if these shaded areas are quite broad, that would mean there's a lot of variation in your blood sugars. And we have here on the slide, like the look that you get in the reader versus the app. And you can see that the richness of the data that you capture in the mobile app, it's a lot more easy to interpret and read that information. And as well, patients can access this on their desktop computer and share it to the pharmacy as their healthcare provider. I hope I answered your question. I'm not exactly sure if that was the question.
The last one, which I think you've touched on as well, there's a few kind of touching on the common theme of interchangeability between the app and the reader. So can you alternate between using the app and the reader? And then also, if you've forgotten your reader, for example, and you bought a new reader or started using the app instead, should that work?
So yes, you can go back and forth between the app and the reader. If you lose your old reader, unless you've been downloading the data into your computer, you're going to lose that data. So if you're a patient that only uses the reader and occasionally you'll upload it to the computer so that your pharmacist can look at it every month. Well, if you went a month and you didn't upload it and then you break your reader or you lose your reader, all that data is gone. Whereas every time you scan your sensor with your mobile device, that data is stored in the app and it won't disappear if it's stored there. So it's it can go to the pharmacist right away, actually. So it's I'd encourage patients as much as possible, if they're savvy enough that they have an iPhone. I think a lot of our patients do. Even my grandma's on the iPad, so I think she could handle it. But I'd encourage patients to use the app just because there's a lot more richness there. Like, I was comparing them myself and just going through the screens on the reader for myself, not having diabetes and trying to read the screen. Some of the details are quite small, and making out the charts, I think, is even harder. So having both as an option, I think, was a very wise decision that Abbott made. So we're coming towards the end of the presentation, just a few more slides. So thank you, everybody, for bearing with us. So we're a little bit overdue, Tiana. So let's try and finish this off. So we're going to talk a little bit about who might benefit most from this technology when we look at our patients with diabetes. And we'll move right into that topic. So the Freestyle Libre, the original Freestyle Libre, is only indicated for patients 18 years of age and older who have diabetes. So pharmacists, we have robust data available to us in the pharmacy as we provide care for our patients. So you might know which patients are receiving insulin, or which patients are receiving combinations of medications that might put them more prone to having a low blood sugar. So for example, if they're on sulfonylurea, or even one of the worst sulfonylureas, glyburide, you got to make sure that these patients are mindful of those risks and what can we do to help them monitor for those risks. Other ways to identify patients who are experiencing low blood sugars, looking at use of products like Bascomine, looking at purchases in the front shop. So if you have a patient that's regularly buying Dex products, that's a sign that they're experiencing a number of low blood sugars, or they just like to eat the sugar tablets, but usually it's they're having low blood sugars. You'd want to have a conversation with them and see how you can support them. Other ways, looking at folks that are spending a lot of, are refilling their test strips or buying lancets often. Folks that seem to be doing a lot of self-monitoring of their blood glucose, maybe they're not aware of this new technology that could reduce the need for finger pricks, and you'd be their favorite person in the world if you let them know of that potential. Anything to add, Tiana?
I think there's a role. Yeah, just that I think there's a role for not just the pharmacist here, but really a team-based approach. Like, you might see that they're filling their insulin or they're on an agent that causes higher risk of hypoglycemia, but people like your front shop staff might be in a better position to notice if they're buying Dex4 tabs, or the pharmacy technician or assistant might be able to notice that when they're trying to bill those test strips to ODB, they're exceeding the allowable amount and it's not being covered. And so having everyone aware of these kind of patients to identify who might be most likely to benefit really helps, because they can either engage in the conversation, asking the patient if they've ever heard about the Freestyle Libre and if they'd like the pharmacist to speak with it further with them. So really a team-based approach there.
Yeah, I really like that. So if you're in a pharmacy that you have folks in your front shop, you know, providing them a bit of education around the topic as well and engaging everybody can really enhance the quality care your whole pharmacy provides together. So we talked a little bit about this when I went over the reports themselves, but what order should you address some of these data that will come to your attention from the reporting? So always your number one priority should be addressing any incidents of hypoglycemia. Secondly, as a pharmacist, your next goal would be to look at the fasting blood sugars and then the preprandials, so the before meal times. And then we can look at broader issues. Once we fix those other problems, we can look at what we call the basal glucose patterns, which includes the blood sugars overnight when the patients are fasting, and then next looking at the postprandial glucose. Anything you wanted to add about this slide, Tiana?
Just that it can be a little bit overwhelming to have so much data now at your disposal when maybe we're used to having a logbook where people have written in some blood sugars that they've noted down. But I think just keeping in mind that like one step at a time is the best approach. And so first taking it and prioritizing the hypoglycemia and minimizing that before trying to address other things through both lifestyle and medication approaches.
Yeah, so low blood sugars, then we look at highs before meals, then highs after meals. And Tiana's absolutely right. Like when I started out not too long ago, I used to have to make out these charts going through patients' readers and writing it all out, all of the different readers, and asking them what they were doing at that time of day and trying to figure out what the trends were for their blood sugars through the week. It's just incredible data, the richness that we have available to us now. And I think a lot of pharmacists may not be taking advantage of this, but as Tiana said, it really is a role that we could handle. So,
so just wrapping us up here.
So that this slide is just some additional resources for you. There are tons and tons of resources out there about the Freestyle Libre. So there's definitely lots of information. Let me just start with addressing that question about the Freestyle Libre 2. So some folks on this call might not know that Freestyle Libre 2 is in fact coming to Canada. And my understanding is that once coverage is in place with third-party payers, that the Freestyle Libre original will be phased out. The price of both technologies is the same. However, the Freestyle Libre 2 brings new functionality, so it can offer alerts. So the patient's blood sugar is having a low blood sugar, it will send an alert. It uses Bluetooth. I don't know the whole details around that, but my understanding would be that you would no longer need to scan your reader every 8 hours. It was Bluetooth. It should be able to communicate with your cell phone directly so that we're not going to lose out on any of the data. And also it's going to be indicated in lower age groups. So it's going to be indicated as low as 4 years old. Other than that, there's not a whole lot more information available for the Canadian marketplace around it.
Thanks, James. We're getting one question, or we got a question earlier, and thank you everyone for joining us. At this point, we're just going to answer questions. So if you're done for the day, it is late, by all means, thank you for joining us, and you can sign out. We will send out the slides to everyone as well. And if there's any questions that we didn't address for any reason, by all means, feel free to email them to James or myself, and we can email you back a response if we weren't able to address you, since we're going a bit over. One of the questions we have here is, do we know kind of the dose effect with vitamin C and salicylates, and is it something that we would see with ASA 81 milligrams daily, or is it more if someone's using regular aspirin for pain relief? And so I'll take a stab at it, but James, pipe in if you have anything to add or go off track. So it tends to be something that's more commonly seen with the higher doses. So vitamin C doses of 500 milligrams per day or more, or higher doses of the ASA. So we wouldn't necessarily expect it as much with the 81 milligrams. But something that you can do is, again, ask the patient to use the finger prick or the self-monitoring blood glucose, as well as scanning the reader, and that should give you an idea as well of how much it's being impacted, since it can vary, but tends to be more associated with the higher concentrations and greater amounts in the patient's blood. Okay. I will see if we have any other questions here that we didn't answer. Give it maybe about 2 more minutes as I scroll here, but otherwise, thank you everybody so much. And for whole health pharmacies and pharmacy partners, again, we will be rolling out some in-pharmacy materials and additional pharmacy operational and education supports in the March timeframe. So we can use kind of what we learned here, as well as those supports to help our patients really be free.
Yeah, that's great, Tiana. And I don't see many more questions coming in, but there's a comment on Facebook. So from someone who's involved in long-term care homes. And they said when residents didn't want to have their blood sugars checked, the nurses found that it made a big difference because they could just swipe the reader and know what their sugars were. So thank you, everybody. Do you have a last question or no?
Yeah.
No? Okay. So
no, I think everyone, we will post the recording.
all right. Thank you, everybody. Have a great night.